and share my screen with y'all. Where is my PowerPoint? Not that one. Oh, here it is. Okay, so like I said, you can see we have 40 slides for today's and several. We won't go through too quickly. There's like kind of some more major messaging that I want to send to all of you. And I would love, like, because we'll be getting a little bit more political in this particular class, in this week's content of class. So please, I would love for this to be more of like a dialogue in terms of just reactions, anything that you have about what we read. So go back a week, going into the Herman text. So putting people who you will be seeing in context, right? So an individual, so I kind of oscillate between, as you guys have seen, victim and survivor, really because that language is up to the person that you are talking to. So same as, you know, if you were to be asking for pronouns, this would also be, I mean, I'm not making an exact comparison there. I'm just saying you're going to use the language that the individual wants you to use, because quite frankly, some individuals who have experienced trauma and are called a survivor find that patronizing. They find that not necessarily dismissive, but it's kind of this, I don't know if any of you are familiar with individuals who have experienced trauma who are like, I don't really like being labeled resilient. Like it feels like it's kind of trying to almost put a silver lining around my experience, or it really feels out of touch to me. So I really want you to just be open to using whatever language the individual wants. So similar, I'll use another example of individuals who are addicted to alcohol. Like some individuals want to be called an alcoholic, like they don't necessarily want that person first language. So again, just many examples for you to honor the person's language. So an individual basically is not a cisgender man. There's some marginalization that experiences, I would argue, a cisgender white man, a heterosexual cisgender white man. There is the experience of marginalization. So the reception of their trauma, it can be very dependent upon their social status, their social position. So if when we are working with individuals, so this is some history, right? And this is where kind of our foundation is when we are looking at trauma and individuals who have experienced trauma, and then where we are today. So our history always informs where we are today. And so just looking at, in the history of our field, of the mental health field, there has been dispute around any sort of post-traumatic conditions. And like, is the person, do they have the right to this? Are they entitled to this? Are they genuinely struggling? Are they genuinely suffering? Or are they just making it up to have some sort of secondary gain, which we'll talk about when we talk about over and under reporting from this week's reading. So even though there's lots of literature around the validity of trauma, there's still debate around like the worthiness of an individual to receive care for differing traumas. So we'll talk about that in terms of, the type of trauma and the kind of the empathy, like the societal empathy around it. So historically, when clinicians have spent kind of like too much time, so remember we talked about like hysteria and these labels and these diagnoses that really necessitated inpatient. So like psych wards, where the stigma is out of control there. So these clinicians would work in these inpatient settings. sorry, that was Siri, would work in these inpatient settings. And if they were to spend too much time with the patient, I'm saying patient because of the inpatient setting, then they were potentially looked at by other professionals as being swayed, or, you know, not being impartial. So like it says here, they became suspect, as though they were contaminated by contact. Like these stories are permeating their mind and making them less objective. So when an individual has experienced trauma, their social context is created by their relationships, not only with those in their like microsystem, those that they're connected to, but also with larger society. And so this is where we'll get into some of the political pieces of our field. Like I said last week, we are absolutely not immune from political influences. Our field is inherently political because families are political. So the social context is created by political movements that give voice to the disempowered. So if you look at history, you'll kind of see this ebb and flow of the validity of trauma, or the push toward the visibility and acknowledgement of trauma. So advances in the field occur when they are supported by political movements. So one of the things that is highly politicized is our research. So our research, for example, informs our diagnoses in the DSM. The DSM is essentially a collection of research. So when a political movement is happening that, you know, heightens the voices of those who are disempowered, raises awareness about, you know, a social issue, then that's when money goes toward it. So you can see the ebb and flow, particularly with trauma, particularly with PTSD, of, you know, post-Vietnam, where individuals who were in the war said, holy crap, like we've got to do something. We are being treated poorly. You know, we've really suffered while we were in combat, watching individuals die, not only those who are, you know, if we're going to on our side, not on our side, just humans dying. And this is really difficult. And the labels that we're given. So by professionals of, you know, being weak, being fragile, you know, these things that are, you know, anti-male in a way. And I say that very, very sarcastically, but at the time, something that was pretty ingrained in society. So, you know, kind of taking it upon themselves to raise awareness. And so therefore that's when funding to the VA was flourishing. So these societal movements absolutely influence our attention on any given presenting issue, or any given sort of like social injustice or something that's happening. Okay, so Sigmund Freud, though a very flawed man he was, he actually really was one of the first individuals to show empathy for particularly women who had, you know, this label of hysteria. And so as he is working with these women, he's seeing this theme, this pattern of abuse and sexual abuse, physical abuse that manifested in this diagnosis of hysteria. So basically, you know, hysteria, for those of you who aren't familiar, it's like a diagnosis of the womb, really. So it's like the uterus was to blame. Like if you had a uterus, you were probably kind of crazy. So when he was working with these women, he had this hypothesis after working with them, through seeing this pattern of hysteria being a result of sexual assault, of trauma. And then as he's, you know, find the data are mounting, these stories are consistent. Many, many women are sharing this. And as an individual who benefited from the patriarchy, who benefited, who had political leanings that didn't necessarily lean toward women's rights, also given kind of where they were socially or historically in that time period, to acknowledge that so many women had experienced this type of trauma. It was unacceptable. It was something that had to be denied. So even though the data are there, the stories are there, it was essentially buried, where he had written about it and then essentially retracted what he had to say because, as you can see at the end of this, it's like hysteria among like low income individuals, or sexual assault, at the experience of sexual assault amongst low income individuals. It's like, well, that's tolerable. But when we get into the more affluent, higher income individuals, this can't be the case. So the credibility or the willingness to accept that truth really wasn't there. And individuals who had influence, who had some power, were able to say, nope, we're not going to do that. So with his, again, this was just something where he has these observations that are pervasive, that are very consistent. The discovery, so initially there was some empathy for that, and then as the political climate changed a little bit, and as these stories kind of threatened the patriarchy, threatened the hierarchy of power, it was something that needed to be buried, that needed to be dismissed, that needed to be pushed aside. So in this section of the book, it moved from talking about women who have experienced sexual assault, and then likening that essentially to the largely male experience of war. So this is what I was talking about when soldiers would come back from war and have these symptoms of PTSD, have diagnosable symptoms of PTSD, and really get questioned for their strength, their manliness. So it was looked at as this, well, you're just weak, you're an inferior human being, because you should be able to handle all of the carnage that you watched, all of the trauma that you experienced. So, oh, sorry, my bad, I also misspelled that. So then psychiatrists were pioneering these techniques to understand the unburdening of traumatic messages or memories. So there was some empathy, there was some movement toward like, oh, maybe this is something legitimate, particularly because there were individuals who held very high status and high regard in society's eye who said, this is a problem, and basically kind of using their platform, using their influence for the recognition of this very real experience. So what the psychiatrists started to do was they started to realize that just talking about the traumatic experiences wasn't enough, that there had to be some sort of integration, some sort of process where there's the ability to talk about the experiences without becoming very escalated, without becoming very activated in the room. So they warned that although hypnosis could expedite the retrieval of traumatic experiences or traumatic memories, a simple cathartic experience by itself was useless. So this is pretty early on. This is, post Vietnam War. And also what the psychiatrists were saying is that treatment would not succeed if the memories retrieved and discarded under the influence of, so it's essentially like a hypnotic, the sodium amytal is a substance that puts the individual kind of almost in a transic state. It's like a different state of consciousness. So if these memories that were brought up in this state were not integrated into their current reality, then ultimately there would be no movement, there would be no healing that would happen. Unfortunately, one of the other thoughts for this was, we got to get these soldiers back in action. So so treatment, or like success in treatment, really was seen as, can you function on a very minimal level? And I'm not sure what the bar was for that, but my sense is telling me that it's pretty low. Then they were considered to be recovered. So what we consider recovery today is nowhere near where these men got to then. So yes, so an integration kind of this war on women and this war on men, or wars that men are participating in that's creating PTSD. So the subordinate condition of women is maintained and enforced by the hidden violence of men. So I just wanted to highlight that for this kind of like dichotomous experience of different genders. So that's some of the like kind of political influence of how we receive and how we treat and how we understand trauma today. I think it's always really important to understand where we were to inform where we are. So we talked a little bit about this last week around, the kind of disparaging use of a diagnosis like or borderline personality disorder, where it's kind of this like sophisticated way to diss somebody, and to really take no ownership as a therapist for that person's healing. And it's by discarding somebody, or honestly just kind of slapping a diagnosis of borderline personality on somebody without being informed by their potential trauma history, is just really doing somebody a disservice. So research has focused on personality traits that might predispose a person to get involved in abusive relationships. Funnily enough, there was no consistent profile of that individual. So it's very interesting to me how some of the waves of research that we've done really focus on the susceptibility of being mistreated, and really not focusing on individuals who mistreat. So there's this enormous effort to explain one person's behavior by examining the characteristics of another. So we're trying to explain a perpetrator's behavior by trying to understand the characteristics of the person that they perpetrate against. So just very backwards, and there's still some research around that, but we're getting away from the idea of trying to understand a person who would stay in a relationship. There's a lot more, we're more trauma informed as a field now, which is movement. So there's attempts to fit the patient into a mold of these existing diagnostic constructs. Remember, our DSM is informed by research. Our research is inherently flawed. So I always say that to keep you critical of the tools that we use, the assessments that we use. We talk a lot, in this class, we talk a lot about different assessments, but I always want to thread in cultural competency and understanding that the individuals, so we talk a lot about psychometrics, about validity, about reliability in our measures, and generalizability of our measures. And the fact of the matter is, largely the individuals that not only create the measures, but the individuals who we test the measures on generally are like white, middle class, heterosexual. So they have these like majority identities that aren't representative and don't necessarily speak for or fit or are relevant for other populations. So I'm not saying to like throw them out, never use them. I'm saying every time you use them, take the findings with a grain of salt and really look at any sort of research that talks about this measure's applicability to other populations, to other identities. So I think that will, again, that will just make you, quite frankly, a more trauma-informed, a more culturally informed clinician, and we need those. So when we take a diagnosis and just use that to explain an individual's behaviors, affect, all of that stuff, you can potentially really just give a partial view of that individual. So potentially even a diagnosis of PTSD as it's defined, as we talked about, I think in week 2 of some of the controversy over it, some of the, individuals in the field who really disagree with some of the changes that were made, it may not even fit. So this portion of the book is really talking about, needing an additional diagnosis. So we know that complex post-traumatic stress disorder, it's not in the DSM, but the conceptualization is used a lot in treatment. There's also a, I'll show you. I think I actually have I have it up here someplace. Sorry, it's, the computer of an academic is always very busy. Where am I here? Okey-dokey, fine. Okay, that's not it. Sorry, guys. I'm just looking. Is this it? Nope. Yes, this. I knew I had it somewhere. So who you'll be reading for next week, more of the neurological piece of trauma, is Besser-Vanderkolk. He is very well known in the field of trauma, one of the pioneers. But he and a group of people, and I can post this into Canvas if you guys are interested, pitched to, so you basically have to submit a new diagnosis to a board that it's like, I don't know, a board of directors or, decision makers for the DSM. And you have to present them with research, present them with data, present them with a rationale for any sort of amendment that would happen in the DSM. And so he and some colleagues put together the diagnosis of developmental trauma disorder, which really focuses, it's very similar to what we've been learning about with complex post-traumatic stress disorder, but it really focuses on the experiences of children and any sort of trauma that is experienced during childhood. And the board was like, nah. And there's politics behind that. Quite frankly, I really encourage you, even though you're not assigned to read the entire book of The Body Keeps the Score, it is really informative. And it's a little heavy, but I think overall it's a really great book that is worth reading all the way through. So one of the themes that we know about trauma and trauma in childhood is that individuals who have experienced trauma in their childhood are more likely to have issues interpersonally, intrapersonally later on in life if there's no, intervention, there's no corrective experience for them. So abuse in childhood appears to be one of the main factors that lead people to seek any sort of psychiatric treatment. I would argue too, this is applicable for outpatient treatment. So I say this because, and we'll be getting into some more assessment later in the class, is always being informed or always holding the hypothesis of something potentially having happened in an individual's childhood. I think it's fair to assume some sort of trauma and then asking questions regarding that. And then if none are endorsed or none are shared, then move on. But I think if we just take presenting issues for what they are and focus on them in the present and really don't do any sort of historical dive in terms of lived experiences, I don't think we're getting the full picture of the individual. So like the next one says, neither patient or client nor therapist sometimes recognize the link between the current presenting issues of something like anxiety, depression, interpersonal struggles, and the history of chronic trauma. So there's a link there in terms of anecdotal, empirical, validated research. And again, I'll highlight for borderline personality disorder, I promise you, if you have not heard it yet, you will hear professionals basically like scoffing at and rolling their eyes. Oh, I've got another borderline. And it just really is unempathetic, and it really isn't trauma informed. And I really, really encourage you to please not engage in that kind of conversation. I mean, I would even encourage you, if you feel safe, to challenge that. So when individuals who have experienced trauma recognize the origin of their difficulties from something like an abusive childhood environment, they no longer need to attribute them to an inherent defect in themselves. So one of the potential benefits of recognizing how a trauma history informs how an individual acts, reacts, behaves, thinks, feels today, can provide some kind of explanation instead of seeing. So one of the presentations you'll see a lot with individuals who have experienced trauma is shame, is, internalizing fault. So it can help liberate some of that to understand the link between something I experienced and how I respond today, as opposed to having no understanding of this and thinking I am just inherently flawed. Like I just can't figure out how to function in relationships. I must just have, chemical imbalances in my brain. I must not be able to be happy. So I want to highlight that of a way to potentially liberate an individual from seeing themselves as inherently flawed. So this can be, I'm making this link and identifying this can be a way to create new meaning of an experience and potentially even like a new identity that is more unstigmatized. So understanding the role of childhood trauma in development of serious disorders informs every aspect of treatment. So remember, there's like an unlearning process. There's a reconnecting process that we'll all talk about today, that mind-body connection. And understanding this provides a basis for a cooperative therapeutic alliance. So giving credence to an individual's experience and informing them, in educating them about how their past experiences affect them today, really is inherently empathic. It's inherently validating. It's inherently creates safety and understanding and vision, meaning I see you, you are valid, you are worthy. I'm going to embrace you as a human. That it can validate any of your client's emotional reactions to whatever it is. It can make some sense of that. And then understanding that these reactions were potentially very adaptive at one point, very protective. And now because their situation has changed, it's become maladaptive because it no longer fits their current experience or their current reality. Okay, so moving to assessment. Any questions, comments so far? I can't see any of you, so if you do have one, please don't hesitate to speak up. Okay, so when you are assessing for trauma and post-traumatic outcomes, first you want to, so these are literal questions that you would ask. You're assessing for imminent danger and ensuring physical safety. First step is, so you're asking them, is there danger of imminent death? So example, by bleeding. These are things that you don't necessarily have to ask, like the client, particularly if they're not able to express themselves in the moment. But these are all questions that you're keeping in mind. So is the client incapacitated to the extent where they cannot attend to their own safety? Is the client currently suicidal? That's always going to be that should be a standard question in your care of anyone, is you're always checking for suicidality. Even if it's somebody coming in and saying, I just want to talk through, a job offer that I got, and I just want a professional to talk through this with, you'll still ask them about any suicidality, just because, one, we are ethically bound to make sure that that person is safe. And two, you just never know. Their presentation can be, it can be not apparent that this is something that they're struggling with. Is the client potentially homicidal? Are they a danger to others? And then that's where you would go through, same as the suicide assessment, in terms of means, a plan, access, all of that kind of stuff. So you would have this baseline question. And a couple of weeks ago, actually, I think last week, we had the CRRS. I forget what the acronym, but it's a suicide assessment. And these are all questions that is like, if the baseline question is yes, so have you had thoughts of killing yourself? Yes. Tell me about recency. Tell me about plan. Tell me about means. Tell me about access. So it's kind of a staged assessment, where there may be a place where they say, yeah, I've thought about it, but it's just been in passing. I've never thought of a plan. I have no idea what I would do. Then you can assume that the risk is low. Oops. And then, so 2, 3, and 4, like I said, are very, very important. And you need to ask both. And then, is the client's immediate psychosocial environment unsafe? So are they vulnerable to maltreatment, potential exploitation? So again, looking at kind of what we talked about with Maslow's hierarchy of needs, making sure that that baseline safety is established before any sort of, like, quote, therapeutic work can happen. So then you're looking for psychological stability and stress tolerance. A common error that clinicians make is that they assess for psychological symptoms without determining if their overall level of psychological homeostasis is there. So they're looking for symptoms or disorders and not seeing kind of what their baseline is. And then if a client comes to you in a state of crisis after a traumatic event, they may not be able to respond to inquiries or interventions. And if you keep pushing, that could potentially lead to like a compromised or contaminated assessment that's really not giving you accurate information. So we'll talk about that. That was highlighted in the reading for this week about pacing and being sensitive to the reactivity of the individual who is in front of you. So what you're essentially assessing is their activation response. So these are potentially intense, often intrusive, trauma-specific psychological states that are triggered by reminders of the traumatic event. So the assessment can be inherently triggering, and that is something that you should be very explicit about prior to performing or conducting the assessment. So you're looking for a person who shuts down. You're looking for a person who may become, overtly pretty agitated. And so it's important to determine the extent to which the trauma issues can be discussed, so that you're not unintentionally re-traumatizing the individual, where you're pushing for details, using language that could be triggering, where a person potentially comes into a state of panic, or I don't even like catatonia or something like that, where they are so activated, they are so overstimulated, they are back in their trauma experience, that they are no longer present at all. That's where I really encourage you, in a trauma-informed approach, would be consistently check what we call checking the temperature of the room, of how are you doing? please let me know if you need me to slow down, if you need to stop. Is there something I can look for in you that would help me determine if you're becoming overwhelmed, if you're becoming activated? Is there something that I can see in you that happens? So really making it this collaborative and very safe environment for you to ask questions. So usual components of an assessment should be initiated only after the person's safety, psychological stability, and capacity to discuss the traumatic material have been verified. So this is just asking questions about their environment, asking questions about safety, interpersonally, intrapersonally, making sure that they are in a state of coherence, that they're fluid, all of the things in a mental status exam that we're looking for, and then talking to them about, their willingness to discuss what has happened to them, and then being very explicit about, like, I'm going to take your lead on this. We will not talk about anything you don't want to talk about. I will get your consent prior to anything. You are welcome to not answer any questions along the way. There are no right or wrong answers. So just being very explicit about that. So remember, just keeping in mind the potential of somebody coming to you after having experienced a traumatic event where they're like, even their bodily autonomy was violated. So, where they have experienced this violation of their kind of like physical boundaries, that it's really important to set the tone in your session of consent, of collaboration, because they've potentially experienced something where they had no agency, no say, or even what they did say was not honored. So just really creating this environment of safety in that way of, I will do whatever feels safe and comfortable and acceptable to you. Okay, so assessing trauma exposure. So in some cases, the client's psychological state is obviously of greater initial concern than how they got there. So where they are with you immediately is, and if they are not coherent, if they are talking in fragmented speech, if they are clearly dissociating or something like that, it doesn't really matter how they got to you this way. You're going to attend to them right now and make sure that they stabilize. I also apologize for all the he or she. That should all say they. So I also encourage you to do that. Just talking in more general gender terms as well. So as you read in both of the books so far, it is quite gendered. There's kind of the assumption that any sort of sexual assault is an experience of women and girls, and any experience of like kind of violence is of men and boys. So just like, I understand that statistically, one gender is more likely to experience one or the other, but I really don't want that to like kind of inform the way that you see people who come in, because that's one of the reasons why there's so much stigma around men and boys who experience sexual assault, is that the thought is that it only happens to women and girls. And then of course, there's not just two genders. So there's the whole spectrum of gender identity, and just being very open to believing the individual when they come in and disclose to you that they've had a traumatic experience. So several studies indicate that trauma survivors are often reluctant to volunteer any sort of detailed information. This could be, again, so, speaking to what I was just talking about, maybe their gender identity and their experience of trauma is not very well accepted, is not very, people don't really acknowledge it. So they may be embarrassed that this is something that's happened to them. Also with individuals who have a gender identity where this does happen, there could be embarrassment about. So I'm just thinking of like women in abusive relationships, that are in a relationship with the cycle of abuse. There's some embarrassment about, like, there's this onus of, you know, why do I keep staying? Why do I keep staying? Like, I should have seen this coming, kind of thing. So again, the overall, but what you're looking for is that presentation of embarrassment, that presentation of shame, and really trying to understand the narrative that the individual, how they're talking to themselves about this, and, you know, kind of what level of ownership they're taking over their experience. So they may also want to avoid being reactivated. And one thing that I think is really overlooked in this is the way that we as the clinician talk about it. So, you know, if you have your assessment and you're, okay, so can you tell me about the rape? That indicates, so I know that was probably a little bit more like overt than some of the discomfort can be, but if you are not very neutral and, you know, kind of, I would argue, confident in the way that you ask the questions while also being supportive and encouraging, your client, particularly individuals who have experienced trauma, they're hypervigilant, right? They're like constantly surveying what's going on around them. They are very attuned to your level of comfort in the room. So if you come in and say, you know, get kind of leery about their traumatic experience that you learned about maybe in their intake, you know, maybe they have bodily injuries, maybe, you know, maybe they've had some self-harm history. And if you're uncomfortable with that, your client is going to read that. So they are also, you know, a piece of this is a sensitivity to others' responses. So they're going to kind of like mold to you. So, oh, my clinician, you know, they're not comfortable, I'm gonna not share because I don't want to make them uncomfortable. So I just really encourage you to challenge yourself in these areas. If you have any sort of discomfort in here, recognizing that individuals who've experienced trauma are quite attuned, and are really going to feed off of your level of comfort. So be confident in those questions. You know, like the words that you're saying, they're not bad words. They're lived experiences that need to be labeled in what they are. So it's not, you know, same as suicide assessments. It's not hurting yourself, it's killing yourself. It is not, you know, the difficult thing that happened to you. It's sexual assault. Like, you label the thing, and that gives permission. By you saying the thing, it gives permission to the client. It says to the client, okay, my clinician is informed about this, they're comfortable about this, they're going to hold space for me, so please don't back away or shy away from words, particularly if you've already done the assessment, to say, how do you feel about talking about this? Okay, we're going to go forward, and you have the gas and the brake. You tell me the pacing, but you as a clinician, you're going to use the language, you're going to say the things that have happened to the individual. You're not going to dance around them. So it's recommended that each client, whatever the presenting complaint, be assessed for a trauma history as a part of a complete mental health evaluation. So again, this very well could be irrelevant in the person's life, but at least you touched base on it. You've covered your bases with it. Often traumatized clients present with a chief complaint like depression, suicidality, some anxiety, maybe unexplained panic attacks. That doesn't obviously include trauma. So again, this is where, as a clinician, we can kind of jump into those presenting issues and not really get a full picture of what's going on with the individual. So it's advisable to still explore those individual symptoms that bring the individual into treatment before delving into possible trauma exposure. So this is the concept of meeting the client where they are. So I think about like, I hope this is relevant to all of you. But I think about an approach that I showed some of my students in a family therapy techniques class, where a family came, and they had it was a mom and a dad. They had a daughter who was, like skipping school, rebelling. And so the clinician immediately went into doing a genogram, understanding like, because both parents were immigrants to the United States, first generation, and just like understanding kind of that, the like immigration experience into a new culture. And the first thing that the dad said was, why are you doing this? Like, we're coming in trying to figure out how to help our daughter. I don't understand why you're asking me about my parents and my grandparents. So what you run the risk of doing is, so if somebody I say that because even though the approach ended up working, like the parents saw the validity in creating a genogram with that, they were initially kind of like thrown off of, I don't understand why you're not at all attending to the thing that we very clearly brought to you as an issue. So a trauma history is something that should happen. At the same time, if someone's coming to you with suicidality or depression or anxiety, and you go immediately into their history, they might be saying, wait, like I came here for this. Why are we talking about this? You have the opportunity, of course, to explain to them your process, your thought, and your approach, why you're doing this. I will say, if you don't attend to the presenting issue that the client has very explicitly verbalized to you, you run the risk of having that client question you in terms of your ability to hear them, to acknowledge them, potentially your competence in that. So I always encourage students to meet the client where they're at. And then once you establish that rapport, once you say to them, okay, your presenting issue is valid, we're going to spend some time here, then you can move into some of that trauma history. Because it's not going to be there. You can get to it, but completely not doing it, I think, is doing a disservice to your client. So like it says here, this allows the client to develop an initial sense of trust and rapport with you before answering also what may feel really intrusive and irrelevant. So building that rapport, building that that therapeutic relationship allows for you to have leverage, right? So come with me. We're going to do a little experiment. We're going to, talk about these things. And if they're feeling safe and heard by you, they're more likely to be willing to go there with you. So I'll go with this slide and then we'll go ahead and take a break. We're moving. So with this historical questioning, so again, these questions may potentially feel very intrusive, potentially irrelevant for an individual. These are like literal script questions that you can ask to the individual prior to getting any sort of, trauma history from them. If it's okay with you, I'd like to ask you some questions about your past. These are questions that I ask every person I see, so I get a better sense of what they have been through. I'd like to ask you some questions about experiences you may have had in the past. If you feel uncomfortable at any time, please let me know. Sometimes people have experienced things in their past that affect how they are feeling now. If it's okay, I'd like to ask you some questions about things that may have happened to you. You can also potentially integrate. So these are like 3 ways to kind of enter into that conversation, but you can also integrate these questions of a trauma history into like a mental status exam or any sort of existing intake that you have, just kind of weaving in questions there. But again, at the top, you're going to say, I ask everybody this, because there's a possibility that the client feels like they've been singled out for like in you asking these things. So really making it overt that, I ask all of my clients this stuff. Okay. How are we doing? All right, let's go ahead and take a 10-minute break. We'll pump through the rest of this and then we'll move into today's reading. And I do have, because we're getting into some of the like more treatment oriented stuff, I do have a relaxation that I'm going to prioritize. Even if we don't get to all the content, I want to start showing you some like meditation, relaxation, different approaches for mindfulness to integrate into your practice. All right, so I will see you back here at 11:08. All right, guys, everyone. Sorry, that's my Midwest addressing people coming out. All right. So let's keep rocking. I'm just going to go over, I'm not going to go over all 67 of these slides. I'm going to pick and choose a little bit here. So if there is anything that I missed, like an aspect of an article or the reading that you really wanted for me to cover and had a question about, please don't hesitate to ask that. So I will go ahead and share my screen. All right. So when you are assessing an individual, sitting in front of an individual, and just so remember, the assessment process, it's not a one-time deal. There are formal assessments where you have them fill out something, and then there's informal assessment where you're just assessment is basically just like getting to know the person, understanding the person in their context, and kind of like testing some hypotheses that you might have about the individual. So just know that the assessment process, it's ongoing. And so as you are sitting with this individual, you aren't just paying attention to what they're saying, you're also paying attention to the nonverbals. So remember, we've tried to quantify nonverbal expression, and it's between 55 and 60% of the time that we communicate through nonverbals. So it's really only like 45 to 40% of the time that we're actually verbalizing with our mouth. So you're going to observe them during the session. We've already talked about an activation response. So you're looking for the sudden emergence of post-traumatic emotions, memories, and/or cognitions in response to some sort of triggering stimulus. So lower levels of such responses can provide information regarding both the severity of the client's current post-traumatic stress and the degree to which their trauma memories can be readily activated by the external environment. So again, you're looking for potential irritation, agitation. Activation means that something's happening, as opposed to like an avoidance response, which involves attention to both the inferred under activation. So that's the relative absence of the expected activation and the visible presence of avoidance activities. This is dissociating. This is shutting down. This is looking away. This is zoning out, which is like a more mild form of dissociation. So it may not be particularly maladaptive in the moment, like they may be looking pensive or something like that, but over time, as we know, the longer that we avoid something, the more overwhelming and bigger it becomes. So you're just looking for that tendency of, moving away from the evaluation in terms of presence, just becoming less present in the room. So then you're looking for affect dysregulation. So this is the client's capacity to tolerate painful internal states. So they're affect tolerant. So when they're experiencing distress, when they're experiencing anxiety, and if they're able to internally reduce the distress without resorting to something like dissociation or avoidance. So this is their dissociation and avoidance techniques are the way that they're trying to modulate their affect. So you're looking for, are they becoming activated? Are they moving? Are they avoiding? Are they becoming less present? So you're just looking for, and all of those indicate an internal state of distress, right? So one way of dealing with an internal state of distress is to express the distress in like a kind of what we would consider kind of a big way, an obvious way, a very expressive way. And then when we're experiencing internal distress, we might move inward but not attend particularly to the distress. We try to like kind of run away from it too, but we're not going to be expressive about it. So, we learn about like externalizing behaviors, internalizing behaviors. Those are the same deal here. And then any sort of relational disturbance. So remember, you're a human in the room. You are a human to relate to in the room. So you can obtain relational information during the interview by observing how the client responds to you and the therapeutic environment. So if they kind of like focus their anger on you, if they call you names, if they, cry and ask for a hug, Like, not that any, like, none of that is necessarily inappropriate. You're just understanding how this person is relating. And again, don't believe that just because you're a professional in a role that negates your humanness. So you are a human to relate to. The interaction that you see, so this is that immediacy, right? So the interaction that you're experiencing with this individual is representative of likely how they relate to lots of people, or it is potentially representative of how they relate when they're feeling safe. And that's the hope, right? That you represent some safety. So then that will give you kind of a look into how they're relating to other people when they're in the state, like mental, emotional state that they are in with you. Any information, anything that happens in the room happens outside of the room. So you also want to be alert to any interpersonal danger. So trauma survivors, they've been hurt, they've been betrayed and otherwise maltreated in interpersonal relationships. So they may respond to evaluation or treatment with hypervigilance or physical or emotional or to physical or emotional danger. So just know, again, anything that happens in the room is data. And I don't say that to like dehumanize the person. All I'm saying is you're constantly gathering information about this human. And so then the client may question you regarding your intentions, the appropriateness or relevance of various assessment questions, and the intended use of any of the information that you've gathered for session. So answer their question. So if you are seeing that they're, why are you doing this? Who are you going to show this to? Like, please don't take that personally. That is them in a space of protection, right? Where they've maybe divulged something and it's been used to really harm them. They've divulged something and they've been shamed about it. They have trusted someone and then it has bitten them in the butt. They may have been in treatment before where they were mistreated by a fellow professional. So remember, you're not asking what's wrong with you. You're always thinking what happened to you. And you want to treat them with dignity in terms of, answering their questions, seeing them as some level of an equal. I mean, I say that some level because you're the expert in the room, but they bring the expertise of their lived experience, right? So it's this collaborative relationship that you're establishing with your clients. So if they show any skepticism, vocalize it, answer it, or get ahead of it. Hey, I'm asking you these questions because XYZ. You've indicated to me that you've had some difficult experiences, and I really want to get a sense of what you experienced to better understand you. Again, if at any time you feel uncomfortable, please let me know. We do not need to proceed. I want to go at the pace that makes sense to you. The intended use of information gathered in this session. You are going to be very explicit about who's going to see them. So particularly for those of you who are in practicum, my supervisor will see this. If you would like to, I'm happy to have you meet my supervisor. As a supervisor, I have gone in to multiple sessions with clients who have been a little skeptical of the process, and I've shown my face because they want to see the human behind the mystique, right? So as a supervisor, it's almost this elusive person, kind of almost like the Wizard of Oz. So ask your supervisor to come in, and again, if they're trauma informed, they would be happy to do that. Or if they're unsure about why you would want them to do that, explain to them why. So just be explicit. There shouldn't be really mystery to what we do. There's no secrecy to what we do. So you also might have a client who has some experiences with abandonment, particularly with individuals who've experienced childhood neglect or rejection. They may be very, very sensitive to any perceived rejection in the assessment or during treatment. So you're understanding the individuals in context of their neglect and rejection, if they've experienced that in their childhood, And so you're assessing this both by how they're describing significant others in their lives and also by their responses to you. So again, you're just because you're informed of the possibility of this being a reality in their history, you're really keening in on how are you talking about individuals in your life? You know, are they hot and cold? What kind of language are they using about the interpersonal dynamics? So these issues of childhood neglect and rejection are really relevant in the work that we're doing. And the issues of trauma and understanding our interpersonal interactions with the client and being very sensitive to how we navigate the room and how we navigate that relationship. So these are where you might have a client who needs reassurance that you're not going anywhere. And so like, I highlight that because, you know, in our field, we tend to be really sensitive about dependence, right? Like we don't want our clients to become dependent on us. At the same time, individuals who have a history of trauma, they may have never had a relationship where they had, you know, this basic sense of safety and consistency and dependability. So it is okay for us to give that reassurance. And I think that that's where we really need to lean into our humanity, you know, kind of as opposed to this very like professional position. So not only do their abandonment issues represent potential sources of distress and conflict, so like, you know, they may be like, can we be friends? Can I have your phone number? And that may be something that you don't feel comfortable with giving your clients. Would it be possible to meet up for coffee at some point? And they could see any sort of the parameters around, you know, the therapeutic relationship as rejection. So just being very overt and explaining the reality. I can't remember if I shared this story with all of you, but I really misstepped with a adolescent who, I'm going to stop this to just like see everybody's faces as I'm telling the story. So for my master's internship, I worked at a partial hospitalization or a partial program in a hospital. So I worked with adolescents aged 11 to 17 who are either in a partial program, so we're there from like 8 a.m. to 3 p.m. or inpatient. So they were there for usually 3 to 5 days, and they were coming in crisis. So after maybe a violent episode, after a suicide attempt, after we had a kid come in who like ate batteries. So we think he may have had like a psychotic break of some sort. So they're coming into us at moments of, you know, real struggle in their lives. So I had a patient who was diagnosed with borderline personality disorder. Again, I think in retrospect, that was probably not very sensitive to trauma. Anyway, so she was in there. We did group therapy as well, and psychoeducation groups. So I was new, I was overwhelmed. None of these are excuses. This is just the reality of my context. And I want to share the misstep because it's going to happen to you. Maybe not this exact thing, but just like giving yourself grace. So she was in the, I think I was running a psychoeducation group with another girl who also had, they had both cut prior to being admitted into the program. So they were like kind of showing each other their scars and some of their fresher cuts, and being relatively disruptive in my view. So again, I'm like this intern, very worried about evaluation, you know, my presence was not fully there in the room. And so they were kind of messing around and I was getting flustered and feeling like I was losing control of the group. And she had said to me, Sarah, we're friends, right? And I was like, I'm not your friend, I'm your therapist. Just like that. So horrible in retrospect, right? Like, and it was fully out of frustration. Like I was fully in my own experience, very not present, super not attending to her. And she shut down, started crying. So I knew immediately, one, that I had let my emotions completely dictate the decisions that I was making. And two, from her reaction, probably did something that hurt her feelings. So I went to a colleague and shared with her what had happened and if there was a possibility of like correcting that. And so she had shared something really meaningful to me. And again, it's, you know, a dozen years later, and I still very much remember this, where I had said, like, how would you have responded to this? Like, I really feel like I messed up and I don't know what would be a better way because I'm not her friend. She was like, well, how you could talk about this or address this in the future is to say, you know, if your definition of a friend is somebody to go out to the movies with or go out to, you know, grab a bite to eat, I can't be that kind of friend. But if you're thinking of somebody, a friend who really cares about you and is rooting for you and is supportive of you and sees you, then yes, I am that kind of friend for you. So just kind of putting parameters around the language and putting some boundaries to, because the reality is we can't be, you know, in every sense of the term friend in terms of having this, you know, like extra therapeutic relationship with our clients. We can't do that. But I was so worried about that boundary, right? Like I was like, no, I have to be seen as a professional. And I really missed out on my humanity. And I really missed out on the possibility of fostering some more safety and some rapport with my patient. So I share that because with individuals who have, I would say like really any client, but particularly with clients who have a trauma history and who do have a history of abandonment, rejection, neglect, of leaning into some of their language while also sharing some realities about the therapeutic relationship. Like when we're done here, you can't call me up and we can't go out and do stuff. That's your license on the line. I mean, you could do that and you're really, really just asking to get your license taken away. So I share that to say, to not be afraid to lean into your humanity in that, but also be realistic about the kind of the constraints of the therapeutic relationship. Anyone have any questions, comments about that? Daniel?
Yeah, I actually witnessed something similar with a colleague. You know, we share presentations and videos and practicum and stuff, and that was something that he slammed the client with, was we're not friends. And it was very, very frank, and it was very uncomfortable to watch because it was very harsh. Yeah. But he was coming out of, like you said, some kind of frustration, because what was being undermined was the relationship, the therapeutic alliance that we had. We're here for the sake of the work, to analyze, to process, to work together. And it was a young guy. So he didn't have a whole lot of friends. We later find out that he didn't have a whole lot of friends. So he's, there's a, like you said, it's a humanistic quality to develop friendship, but it was developing within the professional circle, and he didn't understand that. So the therapist just, you know, kind of hit him with a 2x4 of reality. Like, we're not friends. Yeah. But it was a missed opportunity. Absolutely. To explore, hey, by the way, like you mentioned about the definition of friends. Well, how do you define a friend? You know, and explore that, and then later on finding out that he didn't have many friends. He didn't have a whole lot of experience. So I think, like you said, there's a space to allow a friendship to grow, but it can't go beyond the professional boundaries. Like you say, it's just not realistic. Absolutely. That doesn't mean that there isn't anything authentic or organic about developing a friendship with a client. Yeah. That serves the alliance, really. Yeah. And I had to thank you for sharing that, Danielle. And I eventually went back and had a conversation with her, apologized to her. So again, in those moments, it really is about
humility in that too. I think ultimately so what that was considered is an alliance rupture. Are all of you familiar with the term alliance rupture? So it's, moments where you put your foot in your mouth, moments where you misstep. It's going to happen again. We are not infallible. In 20 years, you will be repairing ruptures. So it's a thing that happens, hopefully not regularly, but when it happens, you address it. So, it's the same as kind of like parents who never apologize. There's no safety in that. There's no humility in that. There's no exchange in that. So if that does happen, please don't run away from it. Please don't think that if I don't talk about it, they'll forget about it. They won't forget about it, particularly in the role that we're in, because the default thought is they will accept me. I am safe. So if you misstep, it has weight. So that's where feedback from your clients is really important. How did we do today? Was there any point where you felt unheard, unseen? Did I say anything weird? Did I say anything off? Or you can kind of just see by some of their nonverbals, right? If you're seeing them shut down, if you're seeing their affect completely change, they're indicating to you that maybe something was either activated directly by you, maybe they were thinking about something. So you want to address what you're seeing. And then if you did something, own up to it. Just like in romantic relationships, right? Or in, close relationships, you're probably closest to the people in your life that you've been through something with, right? You've had a disagreement, you've had something hard happen, and you've talked through it, you've worked through it. And now you're like, man, wow, we went through that together and we navigated that pretty well. It's no different in a therapeutic relationship. There's the opportunity for the relationship to be even stronger after the repair of a rupture. So don't run from them. Address them and know that there's something really beautiful that can happen out of that. Okay, just a couple more slides here. So this is really speaking to our specialty, that interpersonal relationship. So again, this is where that diagnosis, that, slapping on that diagnosis of borderline personality disorder, of, this hot, cold, I hate you, don't leave me. That's kind of the tagline of borderline. But again, if you're looking at this from a trauma-informed lens, you're understanding that interpersonal control, like this desire to really kind of dictate and have a lot of agency over how interpersonal relationships work, is out of a place of feeling no agency at some point. So this experience of helplessness that arises from any sort of interpersonal victimization can lead for later, like almost this like boomerang effect, right? Like I was in this relationship where I was helpless, I had no agency, I had no say. Now what I'm going to do is really try to correct that and protect myself by trying to control everything. So this manifests as an insistence on autonomy, this tendency to micromanage one's interactions with others so that one's own safety and self-determination is intact, and these negative responses to control, perceived manipulation, and influence by others. So this rejection of any sort of attempt to influence the individual, even if it's really benign. So just be aware of that these interpersonal struggles, like these things that are pretty off-putting to other people, can absolutely indicate to you a history of feeling no control in interpersonal relationships. So these behaviors of interpersonal control arise from a fear of being re-victimized by others and often reflect this underlying relational anxiety. So if I get too close, if I allow for somebody to, if I let my guard down, I'm inevitably going to get hurt. I'm not going to let myself do that again. I'm not going to let myself do that again. So this post-traumatic state leads to interpersonal rigidity and sometimes almost this compulsive self-protectiveness. So the default is, I'm going to get hurt, so I have to be in control. So some signs of interpersonal control that can be viewed as potential evidence of a traumatic history or interpersonal violence of some sort. The individual is highly controlling, intrusive, or abusive. take that back. So if you see this interpersonal control, this desire for interpersonal control, these are some things that could have been in the individual's history. So highly controlling, intrusive, or abusive caretakers early on in life. They could have also experienced early emotional neglect with a chaotic childhood environment. So that could be something like caregivers who had substance use issues, caregivers who gave very inconsistent attention or connection. So, you know, we'll talk about attachment too, but like that disorganized attachment of inconsistency from the caregivers of like, sometimes it's, you know, they're very kind and attentive. And then other times for no apparent reason, they are ignoring or not available. And that, because if you're not able to kind of understand that that's like my caregiver's stuff, you can only, and children are very like, you know, self-oriented, right? So they're just they're assuming developmentally too, it's normative that it's got to be something about me. So what I've learned is I can't depend on people. When they're warm toward me, I must prepare for being ignored. I must prepare for some level of neglect. So another thing that could have happened is later trauma experiences that were especially characterized by extended helplessness, like torture or forced confinement. So the first two happening in childhood, potentially something also happened. This number 3 could have happened in childhood, but it also could have happened later on in life where there's an extended period of helplessness. So clinical experience suggests that the clinician will be most effective in this regard to the extent that they don't overly challenge the client's need for interpersonal control. So they allow for some control in that room. And they work to reassure the client both verbally and non-verbally of the benign intent of the clinical process. So, you know, if you come in and I'm seeking help, and because again, our therapeutic relationship, it's inherently imbalanced. We have power in that room. We have the control in that room. You know, we have the power of pacing. We have the power of intensity, and we have the power to just keep trudging through, even if the client is like indicating to us in all the areas that like, I don't want to do this anymore. I'm overstimulated. I am in a state of panic. We have the control to just keep going. It's a misuse of power, absolutely. But just letting you know that when you have this experience of a client trying to really control the process, that what I'm hoping for is your first reaction is, okay, is this indicative of any sort of history, rather than, damn it, this is so annoying. Like I want that the first reaction to be curiosity rather than frustration. So the capacity to enter to and sustain a clinical relationship. So individuals who have experienced interpersonal trauma, like we've talked about, child abuse, rape, torture, partner violence, may experience any sort of intimate connection. So our connection with our clients is intimate, right? They're sharing potentially, you know, things with us that they haven't shared with anybody. So any sort of intimate connection to an authority figure, which is us, we are authority figures in that room, is potentially dangerous. So no matter how safe you are making that space, and you may get feedback from other people that it's like super safe. You're so easy to talk to. This is great. That may not be your client's reality. So please don't take that personally. You can and continue to be diligent on creating that safety. And please don't look at it as a failure on your part. Some clients just really need extended time to actually like buy into the process, to feel safe in that process. Because you don't know, again, maybe they've had a really terrible clinical experience in the past and they are testing you, and it could be months before they let you in on anything. So just remember, whenever you're in doubt about, the clinical relationship or anything that you're building, please don't under recognize the fact that clients still come to you. So they may come to you and not do anything. Like you may be looking and going, oh my God, what are we even achieving here? Sometimes just going into a clinical space is monumental. So please don't forget how much it means that a client continues to show up. That may be their therapy. So whenever in doubt or taking something personally, just remember they're showing up, something is working for them. So one of the goals of assessment is to determine both the client's most obvious relational triggers and their overall capacity to form an ongoing relationship with the clinician. So particularly if you maybe get a client who has been transferred from another clinician or something like that, you may see labels like difficult or manipulative. I would encourage you to try to reframe those, just like we did last week of, these are through your trauma lens, through your trauma-informed lens. Take those labels, and again, it's not what's wrong with you, it's what's happened to you. Also reframing labels like demanding or attention seeking. Again, these are very much put on children as probable effects of trauma rather than this evidence of an underlying personality disorder. So it will allow you to approach the client with a more accepting, non-judgmental, and therapeutically constructive approach. Okay, so I just wanted to share with you, I'm not going to go over these in detail because there's lots of online resources for you to look more into these, but these are some structured interviews specifically having to do with trauma and like post-traumatic stress and some symptoms of that. So there's the CAPS. So this is considered like the gold standard in terms of assessing PTSD. Again, look for cultural sensitivity with the questioning and stuff like that. Also know that in different cultures, and again, that's not just ethnicity, that trauma and the trauma response can mean something different. The trauma itself can mean something different. So then there's the acute stress disorder interview, the structured interview for disorders of extreme stress. That's the disorders of extreme stress not otherwise specified, which is essentially kind of like the attempt at including complex PTSD in the DSM. And then the structured clinical interview for the DSM-4, I'm not sure about if there's anything different in the DSM-5 in turn, like has this interview changed at all for dissociative disorders, so the SCID. And then these are some more general psychological or generic psychological tests, MMPI, both for, so the MMPI-2 is for adults, MMPI-A is for adolescents, the psychological assessment inventory. So these are all things that likely whatever agency that you're at, they'll have kind of their own, what's considered a battery. So a group of assessments is considered a battery. There's the MCMI and then the symptom checklist. So these are all things it's essentially to help kind of inform you about what might the person be presenting with. So again, if, for example, borderline personality is flagged on this. So remember, psychological tests, that's not diagnosis. So what psychological tests allow you to do is then look in the DSM and then look at the inclusion criteria. So if a person, so that's why, like with the MMPI, we always use the term flagged for, which flagged for means look in the DSM and do a more thorough look to see if the person actually meets criteria for anything. So these are also, I wanted to just have a quick place for you to, so, if you have a client who is maybe presenting with some, PTSD symptoms or dissociative symptoms or something like that, that you have quick access to any sort of testing that may be helpful for you in better understanding. So these are all trauma specific. So again, these are looking for things like post-traumatic stress and any sort of associated symptoms, these 4 here. These are assessing for affect regulation, interpersonal relatedness and identity problems. Here are 3 here. And then anything for dissociation, these 2. All right. So I'm going to skip through the preface. Okay. So now another thing that I wanted to highlight here is remembering that any sort of maladaptive coping strategy currently was at one point adaptive. So that, I think that's a safe assumption, was that this thing didn't come out of nowhere. They didn't just do it and was like, well, shit, that didn't work. Let me try it 800 more times. Like, it was effective at one point, and now it is no longer effective. So with complex trauma, so again, traumatic stress responses or reactions, complex trauma is informed in childhood. So any sort of betrayals that a child experiences, like abuse, neglect, exploitation, rejection, antipathy, abandonment, they undermine a child's healthy development by essentially internalizing a schema, so a belief system that, like, the world is unsafe, I am flawed, I am unlovable, I cannot depend on people. So these are, if you think about these formative years of our lives and what caregivers provide us is a sense of identity, a sense of safety. They provide so many things to us. So if it's not there, something has to be built in us. We have to make sense of why things are this way. And then we also have to recognize in our clients that they literally may not know different. So what we would like objectively describe as unhealthy, abusive, neglectful, your client may not be at a space to identify it as such because they don't know anything else to kind of compare it to. So undermining their healthy development by leading to starkly negative beliefs about them and others. So like I said, I am flawed, I am unlovable, can't depend on others, others are unpredictable, they are unsafe. And so they're going to adapt. If that is your baseline belief, you are going to act accordingly. So you are going to have this priority of survival. I can't depend on other people to provide anything for me. Therefore, I must fend for myself. And to do that, I can't let people in, because when I've done that in the past, or even if I've never done that in the past, I know what getting close to somebody feels like. I don't like it. So again, these were initially normal reactions and adaptive to abnormal and recurring traumatic circumstances and experiences. So if that can be your default of at one point, this made a lot of sense, and normalizing that and validating that for your clients as well. So these can become problems over time when these survival defenses are not compatible with their current reality. So they don't have the danger, they don't have the stress, and they're still acting in that way. So they're, maybe pushing others away, being very controlling in interpersonal relationships, which again, in context makes a lot of sense. It also creates a lot of interpersonal distress. So what was once life-sustaining or life-saving at this time of repeated trauma, it interfered with their ability later on in life to function and relate to others in a healthy and like meaningful way. So that's this paradox of trauma of I did something that allowed me, I guess, to get to this place of adulthood. Now, I don't really know what to do with it. So complex trauma, I've talked about it. I've said it a lot. So complex trauma may be based on or associated with an individual's identity. So something that they have no control over. So it says here, immutable characteristics like race, ethnicity, skin color, gender, genetic and medical conditions, and physical limitations, their family, tribal, clan background and history, and other factors like religious or political orientation, class, economic status, and a resultant of power or lack thereof. So, just thinking of these potential traumatic experiences based on something that you can't control. So keeping that in mind too, it may not just be developmental. So giving credence to an individual's identity and the intersections of their identity and how that potentially informs their trauma history. So violence perpetrated in the name of any of these types of prejudices or political and economic motives, this is called identity trauma, because they're based on the intent to discredit or destroy the personal and cultural identity of victims. So again, looking at these characteristics, just like I said last week, being an ethnic minority in the United States is not a risk factor. White supremacy is the problem. Having a physical disability is not a risk factor. It is ableism. Being a cisgender male is not, or I'm sorry, being a non-cisgender male is not a risk factor, it's cissexism. That's the issue. So thinking bigger, thinking of these systems at play that affect individuals and how they navigate the world and how they believe about themselves. Okay, so that's that. I'm going to be done with that PowerPoint. Does anybody have any questions about the PTSD article? Was anything that you read in there that I could maybe open up some discussion about or anything like that? Anything from last week's reading that wasn't clear that you would like me to go over?
I have a general question,
sure,
Dr. Lappin, and it's not really having to do with last week's reading, but in terms of assessments and kind of implementing these specific assessments within our practice, we haven't taken the actual assessment class yet. I'm wondering, do we tell our client, hey, we're gonna do an assessment and we're gonna go over this specific, let's say PTSD assessment, and then kind of just flat out do the actual interview with them? Or do we kind of sneak the questions into, session?
Great question. So you have a couple of choices always. That will always be my frustrating answer unless it's a clear ethical thing. So you can present it so yes, sometimes assessments, you just are like, here it is, we're going to fill it out. And you try to make it as, conversational as possible. So you're not like, what is your name? Where do you live? It's you're not robotic with it. You're incorporating the questions as if you're having a conversation, but it's a guided conversation. And so depending upon, I think, your rapport and maybe the presentation of the client. So if they come in and they're saying, Jada, I am suffering with these things, I think it's PTSD or whatever, then you can say, hey, let's do a formal assessment and then we'll get some more information about this, and then we can, pass it on to whoever for whatever resources that you need. You may also have somebody who presents in a way that I talked about today, where they're having interpersonal struggles, where they're easily agitated, there's something that's going on and you want to get a little bit more information about a potential trauma history, where you have the attending to your own style and being cognizant and honoring the therapeutic alliance and whatever relationship you have. You could be more straightforward and say, I'm noticing these things, and if it's okay with you, I'd like to do an assessment here, and here's why. So you're always giving a rationale as to what you're doing. You could also, at the top of your, in your first session. So again, depending upon your agency, sometimes agencies are like, here's a battery of assessments. And before you start anything that's free form, you've got to go through all of these assessments. So if it's a policy, you're going to go with the policy. But then it could be so if that's the case, you can start it off and say, we do this with everybody, stick with me. And then again, conversational, you're allowing for the client to tell stories along the way if they need to, and just making it as comfortable as possible. Another option in this is to, like you said, kind of weave in some questions here and there. where it could not necessarily be super formal, but you're guided by an assessment. So so again, assessment doesn't have to be formal. You don't have to use the entire assessment. You're really trying to understand more about the client. And again, unless they're like really looking for a diagnosis or like that's the policy of where you're at, MFTs largely, we don't really deal with diagnoses a ton. It's just really not because how we conceptualize any sort of like pathology is relational, and the DSM doesn't really honor that yet. It will, darn it. But as of right now, you know, we're going very intrapersonal, very individual with the way that we're looking at things. So like a formal diagnosis or a formal assessment may not be necessary. You just want whatever information you can get to best inform your work. And again, the default is always explain why you're doing what you're doing. There shouldn't be mystery. There shouldn't be somebody going, you asked me like these 6 assessments. Why did you do that? Oh, that's just what we do here. No, like have a better answer than that. We do this because of this. We do this because of this. And if you're not sure why you do the assessments you do at your placement or at your agency, ask. You should have a very clear understanding about why they chose the assessments that they chose, because there are thousands. So if your standard battery is 4 of them, there was reason behind why they chose those. So you should always be informed about why you're doing what you're doing. Does that answer your question, Jada?
Yeah, thank you.
Okay. Yeah. Any other questions before we move to today's stuff? All right. I'll just start us off for the first couple of minutes, and then we'll take another break. So here we're going to treatment goals and assessment. So this was just in the introduction of the reading. So you want to assess and identify specific symptoms that are most troubling. So you're kind of starting at a hierarchy, right? So you're asking the client, like, what is the most distressing to you? What are you struggling with the most? Just to get an understanding of where they're at. And then I indicated here, because I didn't want to type all this out, pages 88 and through 90 of ideas of how to pose to the client, or the ideas to pose to the client. So these are, just so you guys know what I'm referencing here. So pages 88 through 90 have like goals for PTSD treatment. So again, Sarah Lappin, am very collaborative when I create a treatment plan. You may be placed somewhere that has kind of generic treatment plans where, like, if somebody presents with this, we do this thing. When you are in a private practice or in a place that doesn't do that, you have more leverage kind of to collaborate with your client. So here, I'll just share some examples here. So a goal could be to increase the capacity to respond to threat with realistic appraisal rather than exaggerated or minimizing responses. So these are on pages 88 through 90, 20 essentially goals for the treatment of PTSD. Usually a treatment plan has 3 to 5 goals. So you can offer some of these to your client, like to say, you know, what would you like to prioritize? What would you like to work on first? So just letting you know that those are there. And then these, I wanted to go over the meta goals because I think these are really helpful in guiding. So again, complex trauma that has somebody has experienced in childhood or something like identity trauma. So the first goal is you want to challenge avoidance through attachment security and skill development. So the first 2 goals of therapy for complex trauma survivors address any core injuries that lead them to over-rely on a myriad of avoidance injuries. Understanding what were these core injuries. So when you're talking about attachment, you always are talking about things like a core attachment, a core injury, which means like it's primary, it was formative, it maybe happened first, or it happened the biggest, it's the biggest effect. And then you want to provide them coaching to develop the ability to regulate their emotions. So again, this is going to come out in interpersonal relationships. There is avoidance in the aftermath of complex trauma. It can be kind of convoluted. So it's not straightforward. There's not like this really clear thing to be looking for, or there may almost be like contradicting reasons for why they're acting the way they're acting. And we're modeling a tolerance for some ambiguity and some uncertainty, because we want to offer that for our clients, because our clients who have trauma histories can be much more sensitive and reactive to ambiguity, not knowing. So again, this desire for control. I need to know, I need to have some agency. So it's okay. And we have to model to them, it's okay to not know everything, while also, of course, identifying that they're safe. So it's like, I don't know where I'm going to sleep tonight. Okay, let me model, some comfort and ambiguity. Like that's not something that that should be ambiguous. So this involves the fear of experiencing intolerable and unmanageable internal, physical, and affective states, or of diffuse emotional distress, and the fear of the very people who are also the sources of emotional security. So I'm afraid of what's going on inside of me. I'm also afraid to get close to or divulge or share with people who could potentially help me in this. They could provide some support. So it's this, kind of double-edged sword in that way. Complex traumatic stress can be understood as largely unconscious forms of avoidance in the face of dysregulated emotions and of attachment and disorganization. So disorganized attachment is one of the styles. So here, when you are working to avoid or challenge avoidance and then have this attachment of security and skill development, you can use attachment-based therapies, experiential and emotion-focused therapies, as well as somatosensory awareness-focused therapies. So just some ideas for you of approaches to use that are quite trauma-informed. Okay, let's go ahead and take our last break and come back together at 12:10. Everyone. Okay, cool. Let's finish some stuff up and do some mindfulness. All right, so continuing with these meta goals. Wanting to enhance self-determination and autonomy. So again, these are all, goals that you can work off of and build a treatment plan from. So this requires that you treat each client as the authority in determining the meaning and interpretation of their personal life history. So whatever the meaning is and interpretation is, you're meeting your client there. So again, recognizing that we have inherent power and real influence in that room. Please don't provide expert interpretations. Oh, I think what's going on with you is. So particularly with somebody who has experienced trauma, they can be quite suggestible and like really wanting to find reason for, their presenting struggles. So please be aware of the power that you have in the room. So with this expert interpretation, trauma can encourage other directedness. So the development of this external locus of control, other people are in charge of me. Circumstances dictate my life. I have no agency. So this is informed by the experience in a dominant or abusive relationship, or having a dominant or abusive other, and looking to them and reading them and being very vigilant about their affective state and being dictated by that, knowing that abuse or abuse was coming your way if you didn't kind of like act accordingly or do just the right thing. So, and this is all, doing all of that was in an attempt to maintain safety. Or placating, right? So it's like whatever they're doing to just kind of survive that experience. We should assess the client's attachment style. So there are assessments for this. I think I highlighted it. I highlighted it somewhere. It's in. So the I highlighted and made a note of it in terms of attachment. Did I put it on here? So there's an adult attachment assessment. The adult attachment inventory is by Main et al. 2002. So just potentially something to add to your battery, or just something to have at your disposal. That's something that's available to you for download online. So assessing their attachment style independence needs and balance for their emotional and balance accordingly. So you're looking at what their attachment style, what their needs are, and you are attending to those. You're kind of molding to those. So some clients who have a preoccupied attachment style are more dependent and may require more closeness, whereas others who may have a dismissive, detached attachment style may require more distance initially. So that's kind of you're positioning yourself kind of metaphorically in the room, either closer or farther away from the client. So you must learn about their origin, so you don't take things personally. So you're understanding this distance isn't because the client doesn't like me. It's not because, you know, something that is a personal characteristic of mine. It may be what you represent. It may just be how this person relates to others. So putting people in context makes it, you know, easier for you to understand them and meet them with empathy and meet them with compassion. So in all attachment styles, but particularly with disorganized or disoriented attachment styles, your attunement, predictability, and consistency are very essential. So if you do nothing else, attune to them, do the same thing every time, and do the same thing every time in a manner that is predictable to the client. So another goal is to enhance the ability to manage extreme arousal states. So recognizing that these can be pretty opposing. So going from this state of total arousal to numbness, like feeling nothing. And again, this, you may not resonate with this, but there are theories out there that say numbness isn't necessarily the lack of feeling or the lack of emotion. It can be an overwhelm of so many emotions that you can't really identify any of them. So either way, numbness isn't a very fun place to be in, but just knowing that people can oscillate between these two. So once these states and the coping strategies have been identified, so you're wanting to understand what's it like for you when you're in this state of arousal, what's it like for you when you're in the state of nothingness or numbness. Once that becomes aware, or it's noted, then you can monitor through specific instruction with emotional identification, and then involving awareness of their body state, the visceral processes, so what's going on with them physiologically when they are experiencing these emotions, and then to be able to label these feelings, which they may need some like psychoeducation on that. I don't know if you guys are familiar with like the feelings wheel. It's something that I bring out all the time with my clients. Even those who have been working with for a long time, and it's been, you know, multiple sessions since I first introduced it. Sometimes we're just like, we don't have the quite right word for it. So give them a bunch of words. And also be able to define them. So, you know, delineating between emotions that may seem very similar, you should be able to help the clients differentiate between them. So you want to provide them skills training to be able to have more adaptive and healthy self-management. Increasing the sense of self and personal identity. Sorry, I must have gone really fast with this. So the self concept, like I said before, of abused children is highly negative, and they routinely incorporate the blame of their mistreatment. So again, trying to make sense of why this is happening. So I'm going to internalize this. So the primary goal here is to provide conditions that allow and encourage self-exploration in all the ways that this means. So creatively, sexually, professionally, athletically, interpersonally, intrapersonally. So just like anything that encompasses self-exploration, have them do that. And of course, you're gauging safety and comfort and stuff along the way. So this process of self-exploration is really interrupted by experiences of abuse, neglect, and any form of insecure attachment. So, you know, a secure attachment like the kind of like quintessential example of a secure attachment is, you know, like a caregiver sitting on the bench at a playground, and the child goes away, explores, looks back, makes sure that the caregiver's still there, and they, you know, hey, I'm still here, you're doing great. And then they turn around and explore again, check back in. So it's like the ability to go and explore and then always come back to the secure base. So you may function in that way of like, when I tell you about this self-exploration, are you going to judge me? Are you going to reject me? Are you going to stop seeing me? Are you going to abandon me? So you may be kind of a proxy to that, or a corrective experience for the client. So there is a video here for you. So Siegler's triangular model of self-development, including the brain, the mind, and the relationship. I put a link here to the YouTube video of him explaining this triangle, and I'll allow for you to watch it on your own so we can get to some of the mindfulness stuff. So another goal is to enhance a sense of personal control and self-efficacy. So remember, phase 1, safety, establishing the rapport, establishing safety within the therapeutic relationship. So phase 2 is trauma memory and symptom processing. So this must be timed and structured to support the client's ability not only to tolerate the memories and the emotional responses, but also to gain a sense of self-efficacy along with their life story that encompasses success and growth. So again, is establishing that safety, establishing that therapeutic alliance first, and then also along the way, knowing that phase 2 may need to be paced. It may need to be stopped. You may need to go to kind of like an earlier portion of it, where maybe, you know, something that you talked about in week 5, now you're in week 7, that you go back to week 5. So this can be kind of recursive. So remember, anything that we have that's staged or phased isn't fully linear. So if you are noticing in your client that there's reactivity, there's activation, there's dysregulation, you're going to check in and then potentially like go back to a skill that you've learned previously and keep practicing that. So essentially along the way, you're always scaffolding, right? So if the zone of proximal development becomes too big, if there's too much of a disparity between like the client's skills and what you are trying to do, this isn't going to change immediately. That's where you come back and meet your client. So maintain functioning and overcome co-occurring difficulties. So this sense of chronic helplessness and disempowerment are best addressed by teaching these 5 skills. So again, you're addressing the trauma, you're processing the trauma, and you're giving skills along the way. So it's not like we've established in this class, it's not enough to just talk about it. Now we have to do something with it. Integration is like the ultimate goal of having that, be part of the story and seeing the trauma in a different way that's more adaptive, where the person's empowered and able to move about their life in a healthy way. So along the way, you're teaching assertiveness, you're goal setting for them, not only in therapy, but also some, personal goals along the way, where you can be kind of their accountability buddy with it, but maybe a lot of the work is extra therapeutic. So you're a support source, you're working on the trauma, you're processing that, and maybe they're wanting to get a different job. So you're going to check in with them about that, make sure that they have the resources, make sure that they're connected with the right people that can help them be successful with that. You're going to teach them about decision making. So remember, if you're used to not having agency, not having control, when you have it, you may want to kind of defer to other people, right? Like, I'm uncomfortable, even though this is something I want, or something that I think would be good for me, it's still so foreign that I'm not sure what to do with it. So I'm just going to do whatever other people want, because it's overwhelming to me and very unfamiliar to be making decisions. So that's where you'll talk through that and then help them, make maybe these like micro decisions in the room. And that can be something that you use in the therapy session and something that carries out outside of the room. Problem solving, and then boundary management. So assertiveness and boundary management go very much hand in hand. So again, if you have had like literal body boundary violations, putting up like relational boundaries and stuff is going to be very difficult, because something that's inherently a boundary has been violated. So I'm not sure how to, I'm not sure where I end and others begin, and vice versa. So how do I establish that? So taking some time to understand relational boundaries as well. Another goal is to recognize and prevent traumatic reenactments. So reenactments are the impairment or loss of functioning in an area in which the client would ordinarily, so based on any of their core physical, intellectual, or interpersonal capabilities, they would be able to function adequately or better, if not for the compensatory coping used to deal with that traumatic stress. So in this situation that they're in right now, had there not been a trauma, or had there not been this some post-traumatic stress, how would they be functioning? And if they're not functioning in that way, likely they're experiencing some kind of enactment. So they're coping to deal with this traumatic stress reaction. And that's what a reenactment is. So they can be dealt with over the course of treatment through a hierarchy of interventions. So this is going from like the first thing that should be done to, so it's like the first kind of baseline. And then the hierarchy is kind of involving more and more people and getting more and more like kind of holistic in the approach. So first, you're going to identify other strategies for coping or for improving functioning. Then you want to establish an overarching safety plan that includes specific attention to the reenactments. After that, you're going to create a strategy for safety and interactions that formally or currently abuse others. So this is, potentially if they're having like a post-traumatic stress experience where they are, in combat or something like that, and they dissociate and they become violent toward others, we have to address that dissociation where they may be a harm to others. You want to plan for any sort of parent skill training if that's necessary or if that's needed. So this is something that for those of you who are going through the TFCBT training, you're going to be learning about this if you haven't already. You're going to come up with a workplace plan to counter any sort of harassment or preventing underperforming. A letter of confrontation or reconciliation in a primary relationship, which may or may not be sent. So these are all things that are kind of, a little bit more vulnerable, a little bit more difficult, a little bit more difficult because you're involving more people and being more explicit about maybe that trauma history. And then potentially at the end, a family intervention. So it's, people who are supportive that address safety concerns within the family dynamics. Okay, so let's take a break for just a second from all of my talking, and let me set up some relaxation for all of you. Okay. Where are we? Let's go to YouTube. So I purposely, this is a guided imagery, but I purposefully picked one that doesn't have a visual guide. It's just a verbal guide for you. So before we start, I can't see any of you, so it's okay. But please go ahead and turn up the volume on your computers if you can. Feel free to turn off your camera and get in just a really relaxing, comfortable space. So that could be lying on the ground, that could be sitting in your chair. Just making sure that when you're in your chair that your back, butt, and feet are grounded, that they are anchored to something, so that you're able to be kind of body aware of your body and the space that it's taking up. So go ahead and do that. I'll give you guys a couple of seconds to, if you want, again, turn off your camera, have some privacy in this before I take you through about a 10-minute guided imagery exercise. Just going to check in on all of you really quick to make sure that y'all are good. All right, cool. All right, here we go. I might have a guided it. Yeah, I figured something like this was going to happen because it's
7 out of 10 deaths in the US are caused by chronic illnesses that are preventable, like heart disease.
Guided imagery is a powerful relaxation technique. In this exercise, you will be guided into a beautiful, tranquil forest. As your imagination is guided through various sensory suggestions, your body and mind will respond as though what you are imagining is real. So if you are feeling tense or stressed, this will help shift your mood to one of peace and relaxation. So begin by finding a comfortable place to relax and make sure you're warm. Placing yourself into a nice, comfortable position, either sitting or lying down on a bed, couch, or the floor. And when you're ready, close your eyes. Begin by taking a nice, slow, deep breath, deep into the belly. Hold the breath for a brief moment, and release the breath. Once again, a nice deep breath in, hold, and now release. As you release the breath, let go of any tension, surrendering the weight of your body onto the surface that you're lying on. One last time, deep breath in, hold, and now exhale. Feel yourself beginning to relax and let go. Now imagine you're walking along a path in a beautiful, secluded forest on a bright, sunny autumn morning. The path is soft underneath your shoes. You can hear each of your footsteps against the forest floor, where there are fallen leaves, pine needles, twigs, and moss. As you walk along the path, You can feel a gentle, cool breeze caressing your cheeks. You hear the birds singing and the leaves of the trees as they rustle in the wind. As you continue to walk, you feel relaxed and your mind clears more and more with each step you take. The fresh air is revitalizing as you take a nice deep breath in and as you continue to walk through the forest. You notice the tall trees around you. The red and golden leaves look magnificent, and you stop for a moment to take in this beautiful scenery around you. You notice a red leaf falling from a tree as it dances and twirls in the air before slowly fluttering down to rest along with the others. In the distance, you hear the babbling of a stream. As you look ahead, you notice the sun dappling through the trees, and you see the sun reflection upon the gurgling stream that runs along the edge of the forest. You continue to tread carefully into the forest, over the crackling red and golden leaves, and the broken twigs and pine cones that are scattered across the ground. It is very peaceful here, and the deeper you venture into the forest, the deeper into relaxation you fall, and you're filled with a deep sense of peace and tranquility. You pause a while and rest against an old oak tree, and you feel the rough bark of the tree against your fingers. You look down and you notice a patch of soft green moss that covers a smooth, large rock, and its lushness invites you to sit down for a while. The tree welcomes you to lean against its bark so that you feel comfortable. While sitting quietly beneath this oak tree, you enjoy the peace and stillness. You feel nourished by the warmth of the sun on your body, and you feel a deep connection to all that is around you. You feel the warmth of the sun soothing and relaxing your head, your back, your shoulders, arms, and legs. Your whole body is peaceful and relaxed. Take a few moments and enjoy this deep sense of peace and relaxation. Now bring your awareness back to where you're sitting beneath the oak tree and see yourself slowly standing up. You brush off any leaves or moss that may be on your clothes. You take a final look at the beautiful scenery around you. And when you're ready, follow the trail back as you proceed to leave the forest. Now bring your awareness back to the room. Become aware of the surface beneath you. Notice the sounds in the room. Feel yourself awaken. And when you're ready, open your eyes, feeling refreshed, alert, relaxed.
All right, everyone. You can take a second to come back. Just wanting to, oh, I have some more audio, my bad. Maybe we'll do that one next week. Okay, so any reactions? How was that for you? Anything you noticed in your body in terms of tension, awareness, any general reactions to the guided imagery? Are you feeling relaxed? So this could be something we're not going to do any more class after this. I don't want y'all to fall asleep on me. So this could be something that you incorporate at the beginning of your sessions to kind of set a tone for your client. It's also something that you could incorporate at the end of sessions as kind of a tool along the way. When I was doing my research with psychedelic assisted treatments, we always did a mindfulness at the end, and it was written so the person could take it with them and read it, or we would provide them some audio, because something like this, it's hard to get in a meditative state or a relaxed state while you're having to read something. So we could record ourselves saying it out and give that to them, provide that to them. But yeah, just wanting to, so this was guided imagery. There are many different relaxation formats. So what I'm going to do from now on, keep me accountable to this, is provide you with a different type of relaxation technique and body awareness. So that mind-body connection. So very, very important, particularly with individuals who experience trauma. There's a disconnection that happens there, and mindfulness is a way to reconnect that. And so next week, I'll be providing you with a progressive relaxation. So sometimes you'll be listening to my voice, sometimes I'll be providing you with audio from someone else. But yeah, just wanting to end with that. And get you guys out of here a little early before we dive into some physiological stuff with van der Kolk. That's all I got for you guys.